having for being able to get some time off your very heavy duties in order to participate in this grand round. It's an honor to have you both, and thank you very much for your participation.
Okay, I thank LACE and yourself for the invitation.
Likewise,
Perfect.
thank you for the honor of being here.
Yeah, thank you so much for being here, for participate. And yeah, I will say maybe Professor Noedir can introduce himself first, and then Dr. De La Cruz, and then we can start actually.
I am Noedir Stolf from São Paulo, Brazil. I was full professor and chairman of the Department of Cardiothoracic Surgery of the University of São Paulo Medical School. I am retired from this academic position, and I am emeritus professor of the University of São Paulo Medical School, and senior professor also. And I have basically teaching and research activities at the university. And primarily, I am in a private practice in São Paulo in cardiovascular surgery. I'll share the image of our philanthropic hospital afterwards. We have a very busy, very active service at this philanthropic hospital.
I am the moderator, and I'm Kim De La Cruz. I'm a cardiothoracic surgeon. I am assistant professor of cardiothoracic surgery at Baylor College of Medicine in Houston, and currently the director of aortic surgery in Methodist Hospital here in San Antonio, Texas. Thank you.
So I think we can start, Professor Stolf, and then Dr. De La Cruz, you have the word, and Dr.
Yes, sir.
Stolf, yeah.
Okay. Dr. Diane, president of LACES, Dr. Kim De La Cruz, moderator of this grand round, Dr. Mateo Portas, who's been in contact to organize my participation. And I thank LACES for the opportunity of participating in this grand round. I will present a case of an adult patient with aortic coarctation associated to aortic valve disease and ascending aorta aneurysm. It's not a unique case, but I believe that this subject is very interesting. Maybe there is a lot of colleagues that never had the opportunity of knowing or doing this kind of alternative. I have no conflict of interest. I work in Beneficência Portuguesa in São Paulo, Brazil. It is a philanthropic institution with 3 hospitals. One is in another borough, and the other 2 are in both sides of this street. This one is the largest one. It's 5-building hospitals, all connected on, and the other hospital is smaller on the other side of the street. We have altogether around 1,000 beds. We have around 200 ICU and intermediate care beds. The case is a 22-year-old male patient who was referred to our surgery from another Brazilian state. he informed that he had the diagnosis of a cardiac disease in infants. He has a hypertension of difficult control, headache, dizziness, shortness of breath during exercise. In physical examination, he has hypertension, 170 to 90. There was systolic and diastolic murmurs in the aortic area, in the precordial area. Pulses were augmented in the superior and absent in inferior limbs. In EKG, there are signs of left ventricle hypertrophy. In the radiographic study, signs of enlargement of the aorta. You see here signs of aortic enlargement and discrete enlargement of left ventricle. The echocardiogram showed very normal systolic function, ejection fraction 72%, a bicuspid aortic valve with some degree of calcification of leaflets, reduced orifice area in total discrete stenosis, and moderate to severe aortic regurgitation. Here you see a thickened bicuspid aortic valve and moderate aortic regurgitation. The CT scan showed aneurysm of ascending aorta, 54 millimeters of diameter with bicuspid valve. There is indication of surgery for the aneurysm, a long aortic coarctation, aortic arch hypoplasia, and extensive collateral circulation. Here you see the ascending aortic aneurysm, hypoplasia of aortic arch, a long segment of coarctation, extreme coarctation of the aorta. With the association of a coarctation, aortic valve, and ascending aortic aneurysm, we decide to treat surgically the patient in one single in the same operation. The patient was put in supine position, median longitudinal sternotomy approach, cardiopulmonary bypass with single cavo atrial and distal aortic ascending aortic cannulations. After cardiopulmonary bypass was established, the heart was lifted superiorly, and an incision in the posterior aspect of pericardium was made. Descending aorta was dissected and encircled. A side biting clamp was applied, and an end-to-side anastomosis of 18 millimeters dacron graft was performed. The side clamp of descending aorta was released, and let the graft fill. Then the distal ascending aorta was cross-clamped, and longitudinal aortotomy was performed, and custodial cardioplegia infused in left and right coronary ostia. The aortic valve was replaced by a St. Jude medical prosthesis. The type of valve was previously discussed with the patient due to the younger age and the preference of the patient. It was used a mechanical prosthesis. Afterward, supracoronary proximal aorta stump and the distal ascending aorta was prepared for anastomosis of a dacron woven graft at 26 millimeters of diameter. The graft of descending aorta, completely filled, was positioned anterior to the inferior vena cava and around the right atrium, and anastomosis end to side way to the graft of ascending aorta. I'll show some photographs of the operating field. Here you see the aortic root was preserved, and the enlarged ascending aorta, distal ascending aorta was preserved. Here you see the bicuspid aortic valve with thickened leaflet and the open ascending aorta. Here is the dacron of the ascending aorta, sutured proximally and distally, and an incision and resection part of the ascending aorta dacron graft, and the graft, clamp graft of descending aorta was sutured end to side. The cross clamp was released, and careful the airing through distal anastomosis cathetered in the graft. The heart recovered in sinus rhythm, cardiopulmonary bypass was interrupted, and the patient in excellent hemodynamic condition, only with the use of vasodilator. The operation was completed a routine way with drainage and close of the chest. This is the final aspect of the procedure. The graft of descending aorta, anastomosis in the descending aorta, and passing in curvilinear positions around the right atrium, and anastomosis to the graft of ascending aorta. The patient had a good immediate recovery and was discharged in the 7th postoperative day with anticoagulant and antihypertensive regimen. After 2 years and 11 months, the patient is well, normotensive, only with losartan. In the postoperative CT scan has shown the graft of the ascending aorta, of course, patent and in very good position, and the graft of the from the ascending, the graft from the ascending graft of the aorta in very good position, sutured to the descending aorta, patent, of course. I believe that several points of discussion could be made. And I believe that the first report of extra anatomic bypass graft for treatment of adult aortic coarctation was made by Sideris et al. In 1974. The patient start with a left thoracotomy approach, and due to the adhesions, fibrosis, they turn to sternotomy, laparotomy, and ascending to infrarenal aorta was performed. In 1977, Dr. Cooley groups report a series of patients with ascending aorta through sternotomy and laparotomy, and to distally, preferentially to supracilia abdominal aorta. In 1980s, Dr. Vijayanagar et al. Reported the ascending aorta to descending aorta through intrapericardial approach to the descending aorta. In 1981, Dr. Oliveira, in this report, the technique, the graft was passed around the left ventricle. And in 1981, Dr. Oliveira described the same technique reporting to the Brazilian Journal of Cardiology. Later on, there were reports of single case, reports of series of cases of isolated adult aortic coarctation and coarctation associated to other disease. We have been using extra anatomic bypass graft with two techniques in select cases. And I believe that one point for discussion is the potential indication of the extra anatomic bypass graft in adult coarctation. One of the frequent indications are recurrent coarctation. The other is complex aortic coarctation. And these include a long coarctation. And we have one case of a long, I believe that most of these described as long coarctation, they are actually case of aortitis, probably. And another indication related, but not very well described, is extensive collateral circulation. I'll show a case of this kind of indication. The other potential indication is associated cardiovascular disease, of course, congenital anomalies in adults, valve disease, aortic valve disease, coronary disease, ascending aorta and arch disease, combined disease, usually coronary and aortic disease, valve and ascending aortic disease, the combination of these diseases. And there is also a report of patients with cardiomyopathy with coarctation, and the patient was submitted to heart transplantation and extra anatomic graft. Here you see one patient I have operated on some years ago, a young female patient with an extreme coarctation, but also with hypoplastic aortic arch. And in this particular case, you see here the mammary artery, the internal thoracic artery, and several, four gigantic aneurysm of the collateral circulation. So we decide that the direct approach of coarctation with hypoplasia of aortic artery was not advisable, and we decide to do. Here is another image of CT scan of extensive collateral circulation, the aneurysms, and this particular female patient, 18 years, 19 years, we perform ascending aorta to descending aorta extraatomic graft, and there was disappearance of the aneurysm. The patient is normotensive without medication. This is a patient with hypertension of difficult control, and the investigation that was done in the referring service. We didn't do angiography in the case ourselves, but the angiography showed that the descending aorta had important stenosis. This particular patient was going to decreasing of renal function. There was a stenosis of descending aorta, the thoraco-abdominal aorta, and including in the proximal part of the abdominal aorta, collateral circulation. In these patients, instead of doing like Dr. King de la Cruz would do thoraco-abdominal, we decide to do extra-anatomical bypass from ascending aorta to infrarenal aorta, and the patient recovered the renal function and is normotensive only with losartan. Another point of discussion I would like to start to talking about is the type of extra-anatomical bypass surgical technique. We have the option of ascending to descending aorta, either opening the pleura and accessing the thoracic cavity, or doing intrapericardial. And this intrapericardial graft could be around the left ventricle, as was described by Vina Ganar and Dr. Oliveira, and or around the right atrium, just like we have done in this case I have reported now. The other option is the ascending to abdominal aorta graft. This could be supraceliac, as described by Dr. Cooley group. Later on, Dr. Cooley's group moved from supraceliac to the intrapericardial position of the graft. Or what is really simpler is the infrarenal. I believe that the ascending, descending graft, whenever it's possible, of course, is the best option, avoiding the abdominal approach, avoiding the graft passing through the organs, the structures of abdomen, and a shorter graft. This is the first description of Dr. Vina Ganar, passing the graft around the left ventricle. I believe that whenever we decide to do without cardiopulmonary bypass, the clamping of the graft, side clamping of the ascending aorta is not so easy as when the graft is passed around the right atrium. There is report of a supraceliac distal anastomosis passing the graft in front of the inferior vena cava, and a description of passing the graft from posterior to the inferior vena cava and making the anastomosis side biting clamp to the anterolateral aspect of ascending aorta, just like we have done in the ascending aorta, and we have done in the graft to the ascending aorta and after resection of the aneurysm. The grafts on ascending aorta to the infrarenal abdominal aorta. Of course, we have done in the case of thoracoabdominal stenosis is really very easy. And we can put this graft in several ways. We can do in front of all the abdominal viscera, or we can pass through the omentum and gastroepipelum. This is very easy to do the distal anastomosis. In this case, we have a median sternotomy. It's not necessary to have a very long abdominal incision. It can be shorter than this shown in this diagram. I thank you for your attention. And once again, I thank you for the invitation.
Thank you, Professor Stolf, for that comprehensive presentation. We appreciate you sharing your experience with this particular case of a young patient. For the interest of our viewers and especially the trainees, how common exactly do we get as adult cardiovascular surgeons? How common are these coarctation of the aortas in the adult? Professor Stolf?
Yeah.
Can you hear me, sir?
Yeah, I hear very well.
Yes, sir.
I'm not hearing Dr. De La Cruz.
Yes, sir. Because in our practice, we see about maybe one or two of these a year in San Antonio, and in Houston, it's pretty the same rate. They're pretty rare. A lot of these patients have been treated by the pediatric interventional cardiologist with stents. And how common do you see these patients in your practice, let's say in a year's time?
Oh, they are not so frequent. We have some case of recoarctation. It's a more usual presentation. There is a percentage of patients that were operated many years before and present a recoarctation in adulthood. And this recoarctation, sometimes they are recoarctation. We have case of recoarctation in a grafted foot and other service. And we have, it's not so frequent. And right now, some of our coarctation patients in childhood can be treated with transcatheter. We have done also in our team putting a stent in young patients with coarctation. But there are some patients coming with a long and complex recoarctation, besides the complex coarctation as a primary treatment.
Yeah, most of these patients are seen in the pediatric population, about 5 to 8% in childhood, and they're treated usually by congenital heart surgeons. And then we see the later complications in the adulthood, or there are rare patients that, like your patient that you present with primary. what do you notice are the most common presentation? For us, most commonly they're sent with a CT scan that's already diagnostic of the problem. Um, what are the most common presenting symptoms that you encounter in your practice of patients, adult patients with coarctation?
Oh, well, these patients, they come with difficult control hypertension, take many drugs, and headache, symptoms of hypertension itself. And one of our patients, a patient that we believe it was an aortitis with thoracoabdominal. I show him this case. This patient had also gradual, coming gradually in renal dysfunction because of the malperfusion of the kidneys. And but most of the patients present of difficult control hypertension and the symptoms of hypertension.
Correct, and this is the same that we see all the time. Uncontrolled hypertension is the most common presenting symptom. In the patient that you had presented with us, it seemed like he had also other symptoms like dizziness and shortness of breath. What other diagnostic testing that when they send you these kinds of patients in your practice, what would you order as far as diagnostics prior to
the first patient that we have presented, he had also regurgitation and stenosis of the aortic valve. So shortness of breathiness was due to the double aortic valve disease. Dizziness probably is due to the hypertension. And for the investigation of aortic coarctation, we never do angiography. We always do CT scan. And for the evaluation of the aortic valve and the CT scan for evaluation the aortic aneurysm in this particular patient. For the evaluation of the aortic valve, we do echocardiogram and echodoppler cardiography.
Yes, sir.
We only do coronariography in older patients, not in these patients in particular.
Yes, sir. So yeah, the minimum that you want is echocardiogram and a CT scan to check the heart, the valves, and also the aorta in relation to the coarctation. In this particular patient, there's a bicuspid aortic valve and also ascending aortopathy with the coarctation. As we know, this is a common association. And are there any other, in your practice, are there any other associated cardiac defects that you've seen other than the bicuspid valve and aortopathy?
Well, we had patients with coarctation and subvalvular membrane stenosis, as long as I remember. And we have coarctation associated to congenital heart disease, but then it's easier to correct the coarctation in infants, childhood. And it's not so infrequent congenital heart disease and coarctation.
in this particular case, with the bicuspid aortic valve with aortic stenosis and insufficiency, it was clear that it needed to be replaced. In the era of transcatheter valve therapies, and after you've discussed all this with the patient,
well, it's a very, very, very important point to discuss. In this particular patient, there was a 54 millimeters ascending aortic aneurysm, and after 50 millimeters, there's indication to replace the ascending aorta. This patient had also a mild aortic valve stenosis and regurgitation too. But the aortic valve was not heavily calcified to treat with transcatheter with TAVI. But there was also the indication to replace the ascending aorta. And it was a heavily calcified aortic valve and coarctation. We have the problem treat both diseases. And it was not a heavily calcified valve.
I guess the message is in a young patient like this, a mechanical aortic valve is a better long-term solution rather than a bioprosthetic. Yeah. And besides, you have this more than 5 centimeter ascending aorta that obviously we cannot leave there. Current guidelines say that bicuspid valve and you have a 5 centimeter ascending, that should also be replaced. I guess this is a good segue to our next question, which is as far as approach, extra anatomic approach and median sternotomy, this would be the ideal approach for this case, that you needed to replace the valve and the ascending. Could you comment on that, Professor Stolf?
Yes, we believe that it's the best way to manage this associated disease. It's a median sternotomy. The approach to descending aorta, lifting the heart, is quite easy. You displace the heart and you can palpate it. It's a beating heart, as we have done. You can palpate the descending aorta, or if you incise the posterior aspect of the pericardium, just below the pulmonary, the left and right inferior pulmonary vein, you can go very easily until the descending aorta. And despite we have done the anastomosis, this anastomosis of the graft with side binding clamp, it's even easier. We dissect the descending aorta, we encircle in approximately the length we have to side clamping, because if we have some kind of accident, we never had this kind of accident, we can just clamp totally the descending aorta to correct it. In the very rare case of there was a problem in the anastomosis, etc., we have encircled proximally and distally the descending aorta. I believe that is a very good maneuver in the case of accident. And then with this part of descending aorta encircled proximally distally, we put then the side biting clamp. I believe that this is the best way to treat cardiac diseases associated to complex aortic coarctation.
Mateo, you have any comments?
Yeah, there are some questions in the chat. Maybe both of you, also you as well, can answer them from your experience. I don't know if you see the questions in the chat, but for example, Dr. Juan Contreras, he asked, or he says, I'm going to read it. He says, Dr. Stolf, thank you for sharing your amazing experience. When do you consider percutaneous intervention versus surgery in these cases? When do you consider anatomic versus extra anatomic repair? Maybe Dr. De La Cruz can answer something as well, and Dr. Stolz, of course. Yeah, both of you from your experience.
Please, Dr. De La Cruz.
Yes, I agreed with Professor Stolf's comments as far as, you know, if there are long segment coarctation, also if there are other cardiac defects that need to be addressed, then, you know, median sternotomy and extra anatomic bypass would be the ideal approach. If there's an isolated coarctation, short segment, and it is large enough to accommodate endovascular devices, then and the patient is high risk for one reason or another, then this is a good approach to do endovascularly. Professor Stolf?
Oh, Dr. Contreras, thank you for the observation. For sure, for patients, ideal for percutaneous treatment of aortic coarctation, it's a good decision to do percutaneous treatment of coarctation and later on to treat the cardiac disease, aortic diseases for sure. But these cases are cases that are not amenable, not ideal for percutaneous approach and for anatomical replacement due to the extension of coarctation, due collateral circulation, and hypoplasia of aortic arch not easily treated by a left thoracotomy and anatomical graft replacement. I don't know if I answered your question, Dr. Contreras.
I now see the chat questions here, and I'm going to read them to all of us. Question from Dr. Marin. Given the presence of the massive dilated left internal thoracic artery, would you use this as a coronary bypass graft for a patient with concomitant coronary artery disease? Or would you rather use another graft, such as a saphenous or radial artery?
Well, we had patients with coronary artery disease with previous treatment of aortic coarctation. The internal thoracic artery or mammary artery was not very, very enlarged. And so in a few cases, we made coronary bypass surgery with previous treatment of aortic coarctation. We have used the mammary artery, the internal thoracic artery. The mammary artery was enlarged, but not very enlarged. And so it was actually best than not previous coarctation patients. Probably in a patient with very large collateral, because these patients were treated many, many years ago. Maybe the mammary artery was not, has regressed dilatation many, many years, decades after the operation of coarctation. In the few patients we made cabbage with previous aortic coarctation, it wasn't a problem dissecting and use the memory artery, left internal memory artery, as long as I remember.
So the message is, if we can use the left internal thoracic in a patient who needs coronary bypass, use it.
I believe so. Yeah, it's a point of discussion if in this patient, many years treated, if we have to do angiography of memory artery during the coronary angiography. But I don't believe that many decades after the memory will be aneurysmatic to avoid the use.
There is another question here from Dr. Diane. When would you recommend treatment in an asymptomatic aortic coarctation? No symptoms, but there is coarctation. When do we treat?
That is a very important question Dr. Diane has made. In a patient who is totally asymptomatic, but has hypertension and CT scan showing a very narrow coarctation with hypertension, even if the patient has symptoms, but has hypertension, difficult control, it's very important to see very well collateral circulation in case we are going to do the replacement of descending aorta. Because during the cross-clamp of proximal and distal coarctation, if there is a very good collateral circulation, as Dr. De La Cruz knows very well in his cardiovascular and aortic surgery, there is the risk of paraplegia. That is a terrible complication of descending aorta surgery and coarctation itself.
Yes, I agree with Professor Stolf. If there is uncontrolled hypertension, also if the gradient across the coarctation is over 20 millimeters of mercury, a very coarse way to measure this is by measuring cuff pressures in the arm and the leg. If not, put a radial arterial line and a femoral arterial line. If you cannot cross this stenosis via femoral approach in the cath lab, you can also do a pullback. Put a pigtail in the ascending and measure the pressure, and then compare it to the descending. And oftentimes these coarctations will have very small femoral arteries too, because they didn't get enough flow and they didn't develop much. So that could also be an issue in diagnosing, asymptomatic aortic coarctation. Professor Stolf alluded to paraplegia, and this is a problem. And monitoring intraoperatively, usually we keep the perfusion pressure higher, about 60 to 70 during these cases. We monitor we usually put a left or right radial arterial line and also a femoral line intraoperatively to make sure we're keeping the perfusion pressure at 60 to 70 at least. In kids with the left thoracotomy approach, they measure femoral pressures, and if the perfusion pressure is less than 45, that's an indication to do a left heart bypass to mitigate the effects of the paraplegia in these cases. Oftentimes after the repair, some patients become severely hypertensive. Within 40 to 72 hours, and we use esmolol or nicardipine drip to control that blood pressure and later transition to oral antihypertensives.
Yeah, I believe that this is a very important point to discuss. We measure femoral artery pressure too, especially in case we don't see very extensive collaterals in the direct approach of coarctation. And the mention Dr. De La Cruz made to postoperative care, now we see less and less patients to conventional surgery in aortic coarctation. And in the postoperative period, there is frequently, after correction, either end-to-end anastomosis. In rare cases, we do put a graft. Is very frequent, difficult control hypertension. But hypertension post-coarctation, that is supposed to be a vasoconstrictive reaction of the reflow of distal aorta, the not control of this postoperative hypertension is related to visceral ischemia. So the mention Dr. De La Cruz made to the very good control of post-coarctation hypertension is very important to avoid ischemic hypertension, visceral ischemia.
We have a few minutes. One last question on the technical aspect. You gave us a good tip on how to access the descending aorta from the mediastinum. Can you give us a good tip on how you tunnel the graft if you have to do ascending to infrarenal aorta exposure or tunneling that graft? Or what is your approach? Any tips about that?
Well, in the cases, rare cases, we have to do the distal anastomosis of the graft to abdominal aorta. We have done infrarenal. And the excess of supraciliac aorta we have done, but we don't think it's so easy, the excess of supraciliac aorta. We have to do very carefully, dissect the diaphragmatic hiatus. So it is not extraordinarily difficult, not at all, but it's more difficult access to abdominal aorta, that is the infrarenal. In case of the infrarenal distal anastomosis, we can do passing the graft through the omentum, through the gastroepiploic omentum, but we have done, and just passing the graft in front of the visceral, the omentum, and we had no problem early postoperatively and very late postoperative. And I believe that there is no great problem of passing the graft in front of the visceral organs.
So basically, through the diaphragm, lift up the omentum and the transverse colon and just go through the mesentery and then go down the infrarenal. There is one last question from Dr. Dayan. Is there any role for femoral and ascending aorta cannulation for cardiopulmonary bypass to avoid the paraplegia? because if we cannulate proximally, you know, the flow down to the distal aorta, is that affected? In your experience, Professor Stolf?
Well, in this particular case, we made the approach to the distal aorta without clamping the ascending aorta under cardiopulmonary bypass, but the extra-anatomic bypass can be done also without cardiopulmonary bypass, with starfish and approaching distal aorta, but it's more comfortable under cardiopulmonary bypass. And in this case, we kept the perfusion just like it was before doing the extra-anatomic graft. We didn't cannulate, we just cannulated the ascending aorta, and distal perfusion was done through the aortic coarctation. We kept the cardiopulmonary pressure in very good level. I don't believe that it's exactly necessary because there is the collateral circulation. I don't think it's necessary to cannulate also the femoral artery because the patient was well with and we take good care to keeping a very good level of arterial pressure during the cardiopulmonary bypass.
I agree with Professor Stolf. As long as the perfusion pressure is monitored in the femoral artery remains above 45 millimeters of mercury, that will be sufficient to prevent paraplegia. Well, thank you very much for attending all these grand rounds. And any final message, Professor Stolf, from this case that you presented to take home for our audience in an adult with coarctation of the aorta?
Well, I believe the patients now rarer and rarer with adult coarctation. It's always been a matter of care for a cardiovascular surgeon. The area of aortic coarctation, the patient can present with calcification. The collateral circulation can be extensive. We have to dissect the proximal aorta, distal coarctation aorta very carefully to avoid rupture of collaterals. And so adult coarctation, I'm not advising to do extra anatomical bypass grafted in every adult coarctation. But I believe that adult coarctation has to be very carefully evaluated, the CT scan to see if there is a hypoplasia aortic arch, if there is a very extensive collateral circulation to decide the direct approach or transcatheter treatment.
Thank you. So short segment, good landing zones, good risk endovascular, long segment, complicated, and associated cardiac issues, median sternotomy, consider extra anatomic bypass.
Yes.
Well, thank you, everyone. Thank you, Professor Stolf. Thank you, Dr. Marin. Thank you, Dr. Diane, and all the members of LACES. I hope we all learned from this session, and I'm looking forward to seeing you again in our next grand rounds. Have a good night.
Thank you.
Thank you. Good night.
See you. Bye-bye. Thank you.
Bye.
Saludos.